Hey everyone, welcome to CE21. This month we're talking about HIPAA and documentation. So when we look at HIPAA, we first have to know what's it stand for, right? So it stands for the Health Insurance Portability Accountability Act. So making sure that everything is accounted for, that we don't just freely release patient information to whoever we want to or whoever asks for it, right? The patient's information is all protected. Um, if you have any questions, whether you should release it or not, you should probably reconsider releasing it at least at that time. Um, Figure out who you can and can't release it to. The HIPAA Act very clearly lines out everything as far as who it can be released to, what types of situations you can release information to, and go from there. One of the misconceptions that we have with HIPAA is that we can't release patient's name over the radio. We can't, when we're calling an inbound report to the hospital, that we can't tell the patient or to the hospital what patient we're bringing in. And in all actuality, that's not true. We are able to do that as long as it's pertinent to that patient's care. Right, so some of our STEMIs, our traumas, our strokes, sometimes the hospitals ask us, hey, what's the patient's name? Right, we're able to freely do that over the radio. HIPAA looks at it as we are still doing our due diligence to protect that information because we're using the radio, right? It's not like we're just broadcasting it to whoever we want. Somebody has to take the initiative to go out and get a scanner. They have to take the initiative to go out and do stuff like that to actually get that information. Another kind of a misconception that we have is that when we have two patients in the back of the ambulance, that we can't talk about their information in front of each other. Ideally, no, we won't do that. Obviously, that helps alleviate any of the potential issues that could come. However, if we're not able to talk to the patient outside the rig and then bring them into the rig, ideally that's what we would do. One partner would be inside with the patient, the other one would be outside with the patient, at least getting their pertinent medical information. And then you can bring them into the back of the rig. However, if we're not able to do that, again, try to just keep it brief when you're talking to the patients, and just keep it to more of a treatment base in the back of the ambulance. But again, we all know sometimes that doesn't happen, especially if it's a big scene, something to that effect. They're still looking at it as we're trying to do our due diligence to protect their information. We're still not going out and releasing it to anybody, but we still got to keep it protected. They look at it as you go to a big ER, right? There's a curtain down in between the two patients. That's not a soundproof curtain. We all know that. So the patient next to him is still hearing other patient information. They're still getting, they're still going to hear it. They might not see the patient, and sometimes they do because the curtain goes back and forth sometimes throughout the day, and they can see the patients back and forth. But in the grand scheme of things, we still got to make sure that that we're just not freely releasing that information. So that's how the hospitals look at it, or how HIPAA looks at it, is do your due diligence, and we can kind of go from there. Thing that's kind of common, I shouldn't say common, but it is seen time to time, is at the hospitals or in the front of the ambulances, right? We're leaving patients' face sheets right side up. Anybody can look at that. Anybody can get their information off of it. Don't do that. Flip it over. It takes 2 seconds. We should not be able to walk by and see the patient's face sheet or the patient's demographics, any of that stuff laying face up at any hospital, or any ambulance. If you're walking by, it shouldn't be laying in the dash, clearly visible. It shouldn't be laying like in the center console, freely visible. Turn it over, put it in between your iPad, your tablets, and its keyboard. Just keep it protected. Obviously, we should not be leaving our iPads, our tablets just laying around anywhere. Thankfully, most of us all use a cloud-based PCR now, so that is a plus. I know like ours At all the agencies that I work with, they are set to do a auto timeout at 5 minutes. So if we are not active in that chart for 5 minutes, it automatically logs us out. So if it were to get left somewhere, you're still not going to be able to get any patient information out of it. It's double locked, so you have to log into the iPad. You have to log into the cloud-based program to get to it. Don't go snooping through patients' charts. If you weren't on that call or have like direct patient contact, even if you were on the call, don't go snooping through the chart. That was a very easy way to get in trouble. The major PCR systems that are used track every click you make inside their system. They track every picture that's uploaded, every hospital face sheet, anything like that that's uploaded, any click that you make throughout their program, you're being tracked. Again, that's all to help control HIPAA. So every department should have a HIPAA compliance officer. If you don't know who is your HIPAA compliance officer, you should probably find out. But there should be a risk analysis done, and some of these types of things that we just talked about should be addressed there. You're required to do HIPAA training, I believe it's every year, every 2 years. So you should get some sort of HIPAA training in your department. So again, your HIPAA compliance officer should be able to help you with that. When we're looking at stuff, if you you are going from one station to another or from one department to another for work, say you have a late call, don't take that patient's information with you. Scan it into your chart and have it at the other prospective station that you're going to that way. Don't be taking physical paperwork with you. And if you get an accident in between the two stations, you never know where that HIPAA information is going to end up. And that could end up being a pretty costly error. And same thing goes for like texting information, right? We don't text patients' information back and forth, even a name and date of birth, stuff like that. We should not be doing that. When we are, if we're working between two departments, you can fax it to them. It should have a fax cover letter on it saying obviously this is all protected, etc. And last but not least, that we shouldn't have to say, but we still got to emphasize it, is don't post it on social media, right? If we are at an accident scene, don't post pictures of the car's license plate, etc. There's nothing worse than having a loved one find out something happened to like a family member or a very close friend of theirs, something to that effect, on social media, because we posted something that we shouldn't have. You might think that you can send a Snapchat to like your close group of friends. Yeah, until that gets screenshotted and sent to 10 more of their friends and 10 more of their friends. Guess what? Now the family has it. We don't want that to happen. When we look at fines for HIPAA, they start as low as $100 and up to $50,000 per incident. I don't know too many people that could just willy-nilly write a check for $50,000. I can't. And the federal government has a cap of $1.5 million per calendar year per incident. So if it happens more than a couple of times, you could definitely face some very high penalties. And even as far as departments go, yeah, we carry insurance to help in situations like that. But again, I don't know too many departments that could write a check for $1.5 million and be okay. So do your due diligence, protect the patient's information. Don't just go spreading whatever you want to spread or sharing it with whoever you want to share. One last quick note is for a crime scene, an active crime scene, we are able to release information that is about the patient to them. If it's an active crime scene, obviously, so the state says that we are mandated reporters for elderly abuse, child abuse, etc. Again, we have to disclose their information to legally report that. So again, we are allowed to do that. So kind of changing gears, when we start looking at documentation, again, I know documentation is definitely not anybody's favorite thing to do. It's probably people's worst things to do when it comes to taking care of a patient. Yes, it's no fun, but at the end of the day, it's still a very, very important part of our job. So we provide good, high quality patient care in the back of the ambulance, on scene, etc. We still have to go back and document all that. You can't, as nice as it would be sometimes, just writing, we went there, saw this, did this, cleared. That'd be pretty nice, but it's not enough, right? We have to do our due diligence to make sure that we're documenting every intervention that we do, every med that's given, any IV attempt that's attempted. All of that stuff plays a role in these patients being treated appropriately down the road. We can see stuff on our cardiac monitor that by the time they get to the hospital is fixed, right? Somebody in SVT, we can give them meds and correct that in the field. We can give them electricity in the field and correct that. If it's corrected by the time we get to the hospital, they're not going to see it. So again, making sure that we document that type of stuff is very important. As far as I tell my crews that yes, we provide good quality patient care. That continues with the documentation. If we are cutting our nose off to spite our face in documentations, spite charting, oh, the patient had their bags packed and met us outside, blah, 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 no reason to go to the hospital. That's not doing us any good. It's not doing the patient any good. It's not doing your department any good. And it sure isn't doing you any good. When we look at things like that, those are automatic denials for insurance, Medicare, Medicaid. You're not going to get paid for it. And now you stack the patient with the transport bill that potentially could very easily be covered with Medicare, Medicaid, or insurance. So keeping that in mind is a big thing. I don't know too many departments, if any, around here that could survive without any reimbursement from Medicare, Medicaid, or insurance companies. Right? So you do that too long, you're not going to get the money. Granted, we shouldn't have to be the ones worrying about the money, but we're also doing the patient very wrong by doing that as well. They called the ambulance. They thought they had an emergency. Even if it's a stub toe, it's an emergency to them. We went there, and now we're taking them to the hospital for evaluation. So we had to bandage a toe, right? We had to help them to the ambulance because they're hobbling on one leg, right? So we're taking them to the hospital for evaluation. Again, it's very easily charted for all that stuff. Putting no patient had no complaints, no injuries, for an impression is not a good thing to do. And there's very, very few incidences where that should even be done. Any transport we're doing, they have some sort of complaint. They're not just like, hey, you know what? I feel like going to the hospital today. Let's go for a ride. I've never had a patient like that. Making sure that we have good grammar, proper spelling, stuff like that in our charts is important. Again, it seems like a very silly, simple issue to have, but if it were to go to court, lawyers love finding mistakes like that, because now they can start using that to show that you're an incompetent medic, even though it's probably not true, or I'd hope it's not true, but little things like that, they start nitpicking. They love to do that. So don't give them the option to. Narratives that don't paint a very good picture. I remember when I was a medic ride time, I called the radio report in, one of my first ones as an ALS provider. to OSF, and the ECRN, when we got to the hospital and dropped that patient off, came out and just chewed me out, telling me how terrible it was. You gotta paint this a good picture, blah blah blah. I was like, oh yeah, cool. I don't paint. Needless to say, I shouldn't find that very funny, but at the same time, like, I realized that I needed to work on that, and as I continued to grow as a provider, I realized how important that is. Right? When we call a trauma in, for example, we have the few things that we can call a true trauma alert for. However, if you call and paint a very good picture of what you have, what you found, and what you're doing, there's a very good chance that they're going to have the full trauma team there when you get there. Even though we can't, it's not technically a trauma alert. Every trauma patient should have a GCS documented. Again, trauma alerts, trauma teams, that's what they want to know when the ECRN picks up the phone and calls them and says, hey, we have a trauma coming in. They want to know what it is or what's the patient's GCS. Those are little things they start using to figure out, are we going to make this a level 1 trauma or level 2 trauma? Are we going to keep it here? We're going to try and fly it out. What are we doing? We, as providers, should not be making subjective conclusions or stating our opinions in the chart. Keep it factual. Document objectively. Just because we felt like it was a call that didn't need to go to the hospital. It's not our job to state that the patient is, quote, abusing the system or anything like that. That's for our administrators, for the hospitals, for PD and all them to start working on. It's not our job to document this is an abuse this is an ambulance abuse in our charts. Obviously, when we're doing our narratives, there's several different ways to do them. You can use the SOAP method, you can use the chart method, the DART method, all of these different things, or just a simple timeline, chronological order narrative. It's really up to the provider at this point. For me, I tend to start from when I got paged, got on scene, what happened at the hospital handoff. I personally find that the easiest for me to do a timeline chronological order narrative, because we're already putting that in the flowchart in a timeline. So yeah, personally, I find that the best. I find that I don't miss stuff that way. When I used to try to do the chart method, it was very difficult for me to learn, mainly because it wasn't a nice, smooth flowing timeline or narrative from the start to the end. So again, it's totally provider preference, but as long as you can document all your information and everything that you did in there appropriately, that's what matters. When you have to do addendums, it's important to have them time-stamped appropriately, to make sure that they're being documented appropriately. If you miss something or think about it later, add it. State why you're doing an addendum. And realistically, those should be done within the first couple days, or on your next shift. It should not be done 2 to 3 months out, right? Then it tends to look like you're trying to hide stuff. It looks like stuff may or may not be accurate. Usually with the cloud-based programs that we use now, you don't have the choice when it comes to time stamping them. It automatically does it. So when we're doing our narratives and our reports, failing to address the medical necessity of the patient or the levels of service that we provided to the patients clearly in our reports is a thing that we tend to see more often than not. Not so much the medical necessity, but sometimes justifying why we did ALS interventions or why we made it an ALS call over why it wasn't BLS, stuff like that. Documenting that we gave the patient a neb treatment, and initially they were speaking 2 to 3 word sentences. After the neb treatment, they're now 4 to 6 word sentences, and just kind of going from there, right? It shows that there was improvement in that patient care. Yes, lung sounds got better. But simply stating the patient improved after the neb treatment doesn't cut it. It doesn't show that our treatments were appropriate. Documenting and showing that, they were speaking 2 to 3 word sentences, we gave them a neb treatment. They were still at the 4 to 6 word sentences, we gave them another one, started an IV, gave them Cyanmedrol, went down the mag sulfate route. By the time we get to the hospital, they're speaking full length sentences. That shows a very good progression of why we did all of our interventions, why that patient was treated at the ALS level and not the BLS level. And it explains all of that. When it comes to documenting our medications that we're giving, personally, I tend to just document the names of the meds I give in my narrative. I don't put the doses with them. Mainly because I don't want to have a typo. Instead of putting like 2.5, put 3.5, etc. It's just something else that if it were to ever go to court, that lawyers could basically nitpick. Again, we don't want that. So make sure it's documented appropriately, the proper doses. That is a flowchart type deal. Putting all of our meds and doses there and just putting the med names in the chart, or it was even stating that it was given per the chart, so that they can look back into the flowchart and say, oh yeah, they gave this, and here's how much they give, here's the route they gave, etc. That kind of ties into documenting our interventions, right? Just because we start an IV on somebody in the insurance, Medicare, Medicaid realm of things, that doesn't mean they're going to pay at the ALS level, right? We could start an IV on everybody we wanted to. If it's not justified, they're not going to pay you. So, again, making sure your interventions are that you can justify why you did what you did. At the end of the day, that's the biggest takeaway for documentation and providing or proving that we did the correct thing for the patient. Last but not least, obtaining signatures. Again, it's nothing fun, and it's super easy to have the nurse sign versus the patient sign. But if your patient is alert and oriented ×4 with a GCS of 15, unless there's an injury to their hand that they write with, they should be the one signing, not the nurse. Because you feel like being lazy and having the nurse sign for it doesn't mean you're going to get paid. And actually, they can use that to justify not paying you. Right? That signature shows that it's okay to release their information to insurance, to your billing company. In the grand scheme of like HIPAA and Medicare medications and stuff like that, they could go to research. We can use it at the EMS office, right, for education. That release is what's saying, yeah, it's fine to do that. So without it, you're kind of putting yourself in a real big pickle there. So get those signatures. Don't just take the easy way out and have the nurse sign. Obviously, if they're, have dementia, Alzheimer's, their GCS is 13 or less, by all means, the nurse can sign. If it's a suspected COVID patient, that is one thing they did with COVID is that, if you have a COVID patient, it's okay to have somebody else sign on behalf of the patient to help keep a distance between us and the patient, or to prevent them from coughing on their hands, stuff like that, and getting all over our tablets. So that was one nice thing they did with it. So if you have any questions in regarding documentation, feel free to reach out to the EMS office. Chris up there is a very good resource for all that. I know when she comes out and teaches, half the time she does talk about some documentation things as well. As far as the HIPAA stuff goes, again, every department should have a HIPAA compliance officer that you can reach out to with any questions or concerns there. Again, the web is also a very, very good resource for a lot of that stuff. So if you have any questions, feel free to reach out. Otherwise, we'll see you next month.